please. Hey everyone, good evening and welcome to our March Public Health Preparedness webinar. It's crazy that it's March already, but welcome. And I am very excited. As I mentioned last month, this is the 20th anniversary of public health preparedness at Penn State. So this year, my plan is to focus all of our webinars. Thanks, Michelle. I know it's exciting. I'm very excited about this anniversary because it's been amazing to see the program grow and expand and have so many amazing students come through. So I'm super excited about this. And one of the ways that I want to commemorate it is the webinars this year. I am reaching out to people who have some sort of Penn State public health preparedness link. So I kicked it off last month explaining a little bit about the program and my background. This month we have Gavin, who you all know, and next month on April 1st, we're going to have Dr. Rob Cherry, who was actually my advisor when I was a student, and he was the person who brought who started the program. So he was the very first program director, and under him, it was the Master of Homeland Security in Public Health Preparedness. So all of the other options and everything were an expansion on what he started. So he's going to talk about how the program started and how it grew under him, and also some of the great stuff that he's been doing since then. I believe he left in about 2010. So he was here for the first few years of the program, and obviously has done some amazing stuff that we were able to build off of. So a couple quick announcements before I turn it over to Gavin, who is the reason that we are all here tonight. First, next week on March 10th, we're going to be having an IAEM meeting. So if anybody's interested, feel free to join us. March 16th, as some of you may have seen from our announcements. So we have a monthly book club, and right now we are reading The Big One by Dr. Osterholm. And next month, or this next in 2 weeks, sorry, we are actually going to be able to have him come speak and do a fireside chat with the book club. So our the book club, I'm going to say, is very relaxed. If you want to come and you haven't had a chance to read the book, but you want to listen, feel free to come. If you want to, participate in the discussion, you are more than welcome. If you just want to listen, you are more than welcome to do that too. We would just love to have you attend and be part of it, but no pressure if you don't want to speak. But on March 16th, I would definitely recommend, if you're interested, coming, because we are so, so, so excited to have Dr. Osterholm come and speak. Dr. Cherry is going to be doing our PHP webinar on April 1st, as I mentioned. And the other big announcement is also part of our 20-year celebration, is this summer we are going to be offering a special topics class. It's going to be a 1 week in-person class in Hershey during the week of July 20th. So if you are interested in registering, it's PHP 597. And it's going to be a public health preparedness from theory to application. And I'm going to be doing it with Scott Michelonis, who is the head of emergency management at Penn State Health. And we're going to have some guest speakers. We're going to be doing some tabletop exercises, going to be visiting some things in the Hershey area. So super excited about that. It's the first time we've ever done anything like this in the public health preparedness program. So if you're looking for a summer elective, please look into that. Registration is available for summer classes. So if you are going to be taking classes in the summer, please look into those regardless of whether you're doing 597. Can you send me your contact? Oh, sure. Yes. So summer registration is open. As many of you know, I have taken over advisor position for Dr. Lengerich. So if you are a current PHP student, I am your advisor. I am going to be sending out a bulk email about that. But as always, you can reach out to me if you have any questions. Last thing before I kick it over to Gavin is I will be monitoring the chat. So if you have questions for him and you are unable to unmute, just feel free to put it in the chat and I will read it off to him when there is a break in the discussion. So, Gavin, I will turn it over to you and thank you so much for speaking with us tonight.
Fantastic. Thanks, Jen. Let me just share my screen. How's that look, Jen? Does that work?
Looks good.
Okay, so Dr. Cherry left uh, the program 2010. I started 2011. So never got I actually got to meet him, but I came on for some of the people I'm going to talk about. I'm going to include in my discussion, especially when we get to talk about Iraq. Craig Vanderwagen and Dave France is the reason I got to Penn State, and that was back in 2011. So I've been there nearly, oh gosh, 15 years now. I teach three courses, which I'll go over in a second, but today I want to emphasize opportunities for everyone as graduate students, as well as when you graduate, on how to go from classroom to being deployment ready. And I've emphasized this in the courses I do teach at Penn State, is that knowledge is fantastic, and I'm here through our program, our Masters of Homeland Security program, to give you some knowledge, but you really do need to get down and dirty and get some hands-on real-world experience. Let me. So a little bit about myself. So I was 12 years in the military, 8 years in the Australian Army, 4 years in the British Army. That took me to Northern Ireland for 12 months in 1994. It took me to Bosnia in 1996 when I was part of NATO headquarters. But really, what brought me here was to the US. I worked in Bolivia for the British government back in 1998 to 2000, running a program there that looked at human trafficking, wildlife trafficking, drug trafficking. And there's only one Irish pub in Bolivia. It's in Santa Cruz. And I spent a lot of time in that Irish pub because that was where we all went. And we were sitting there one day and these Americans walked in and they said, "Are you Gavin?" I went, "Yes, I am." They said, "Do you run this program?" "Yes, I do." And they said, "Well, we just bought your program." And I went, "Oh, that's really funny. Let me buy you a beer." Actually, they serve Guinness here. "I'll buy you a Guinness." When I went to the bar, I rang the ambassador, Ambassador Graham, and I said, "Ambassador Graham, these Americans just turned up and they said they bought my program. What's going on?" He goes, "Oh, Gavin, I meant to tell you about that." And I said, "Well, what do I do?" He goes, "Well, go back and talk to the Americans about getting a job." And that's exactly what I did. And I ended up at CDC, and I was very fortunate and very grateful at CDC to become part of the Epidemic Intelligence Service Office, and then did a few years there, and then came to DC to State Department and the US Government Agency for National Development. And that's how I came to America, gosh, back in 2001. So I teach three courses at Penn State, PHP 510, which we're going through right now, and I emphasize to all my students in 510 is I can give you knowledge in a 15-week course. You'll have assignments, both team-based, individual-based, test your critical thinking skills, but really we have to focus on how to get you on the list for deployment. In the summer, I teach PHP 832, which is the fundamentals of biorisk management, which is aligned with ISO 35001 biological risk management, which really came from the CEN European Workshop 15793, which I was part of development back in 2008, which looked at biological risk management as a system. And so we cover the principles, methods, and competencies for developing, improving, and evaluating a bio-risk management system. And then in the fall semester, I teach PHP 831, Public Health Preparedness and Emergency Operations Plan, which really focuses on HACCP and teaches you the fundamentals as well as providing templates on emergency preparedness exercises, orientation, tabletop drill, functional and full-scale exercise. And it's been this course, this PHP 831, which has really put a lot of students ahead of others. I know how competitive it is out there to get a job. And so many of the students that have done PHP 831 have used that to get ahead of the competition to get a job, whether it be at local emergency management agencies, state, government, federal, or even the private sector. And I've had a couple of students that said, "Oh, I really want this job in North Carolina. I really want this job in California. What should I do?" I said, offer to give him a free tabletop. Give him a free tabletop and use the skills and the templates and what you learned in PHP 831 and let's see what happens. And every student, there's about 6 students that have done that over the years, has gone on to be employed by the organization that they gave the tabletop to. So one of the challenges that we have in public health preparedness, disaster medicine, emergency management, is that we have a problem imagining what the disaster looks like. We have a problem of thinking how big or what the impact is. And this is a photo you see often from Japan, March 2001, where the earthquake I think it was an earthquake of a Richter scale about 9, led to a tsunami, led to hitting the nuclear reactor, led to a meltdown, led to thousands, hundreds of thousands of people having to be evacuated, led to a food crisis, led to global impacts, and that cascade of events is something we're really challenged always when it comes to disasters on thinking about what is that cascade. And so when I talk to my students about deployment ready, I tell them knowledge alone is not enough. It's wonderful you're at Penn State, you're doing a master's program, that is going to help you, no doubt about it. But there's a difference between academic preparedness and operational readiness. And there's understanding that public health emergencies are both human, political, logistical, emotional, and as an epidemiologist, not just epidemiological. And now, when I was talking to Jan preparing for this presentation, I actually got a call from the United Nations. Would I like to go and deploy? And could I fill out this form? And, oh gosh, this is a great snapshot. And I took a snapshot as I was filling out the form for the United Nations. And I want to go through. This is a very high level position, around about the incident commander position for a deployment that the UN is currently doing and wants replacements to come through on a regular basis. It'll be about a 3-week deployment. But on this form, it talks about list your international operations, which I've listed a few there. And I want to emphasize something. It says, have you worked with the UN cluster system? Now, we can teach you that. We can teach you what the UN cluster system is. But have you worked with the UN cluster system in the field? So you have to provide real world examples. Have you operated using sphere standards in the field? And I cover sphere standards in PHP 510. And then again, are you able to deploy for a minimum of 15 days? And I think they came back to me and said it's actually going to be about 3 weeks. So let's have a quick look at the UN cluster system. There are courses. They are freely available. You don't have to pay for any of this. You can go to the United Nations website. You can download the material. You can have the audio book version and just sit there and listen to it, read yourself. But understand that humanitarian emergency relief systems under the UN cluster system looks like this diagram here. Food security, health, logistics, nutrition, water, sanitation, hygiene, early recovery, education, telecommunications, camp coordination and camp management, anything from prevention, mitigation, preparedness, disaster response, recovery, reconstruction. That is the UN cluster system. And so what this application was asking is, do you know this theoretically? Yes. Have you then can give examples where you've actually been part of the UN cluster system? And the other requirement was the sphere standards. And my students in PHP 510 have just gone through an exercise on the sphere standards. There are courses available that are free to do and learn about sphere standards. But what I emphasize, if you're going to just do I know sphere standards, take that one step further and become an instructor. If you're going to do stop the bleed and learn how to put on a tourniquet, take that one step further and become an instructor. And this is really interesting because in the exercise that we did on sphere standards, every student in the class except for one sent in their answer using the metric system. And they're talking about grams and kilograms and milliliters and liters and centimeters and meters. And I went, that's great, guys. Go and get me 15 liters of water. You can't do it, can you? Because here in the US, we're one of the three countries of the world that still uses the imperial system: Liberia, Myanmar, and the US. And what I was emphasizing, if you want to, it's great. You can use the imperial system when you deploy here in the US, but even when we deploy in the US, we are now using the metric system. And if you want to learn and be available and be qualified to deploy internationally, you have to start understanding the metric system. And you have to understand that when the language we speak and how we work operationally is grams, kilograms, milliliters, liters, centimeters, meters. And it's really important. And it was really interesting. Only one student just recently in the assignments that we had converted the metric system to the imperial system, which looked like an absolute mess when you write it down on a piece of paper. But everyone else gave me their answers back in the metric system. And then we started having our office hours that week. I'm going, oh, good, you guys understand the metric system. And it's no. So part of what we should be doing at Penn State is teaching you both in imperial system, inches, feet, pounds, as well as the metric system. There are other freely available courses that will help you with deployment. You get a FEMA student identification number. That's free. You then go on the FEMA independent study courses. And again, when I deploy in the US, we get so many people. The first thing we look at in their application, have they done 100, 200, 700, 800, 4 courses at a minimum? If they haven't, we don't even look at anything else. They're off the list because we're trying to decide how to pick the team and who we deploy with. All the courses that I've listed here are free. So if you want the bare minimum requirements to get onto my team for deployment here nationally in the US, you will need to do 100, 200, 700, and 800. If you want to come onto my team and have some sort of decision-making role, you would have to have done ICS 300 and ICS 400. That's 6 courses and they're free. It just takes time. And I really want to emphasize, use those resources at the federal government level through FEMA that helps you become part of a team that deploys. And that's what this is really, really important because this is what we do for every deployment. But I also emphasize that if you're going to deploy, get a skill that no one else has. Go and get your chainsaw operator license. Get that little piece of paper like I have, so when you walk in the room, they go, "Who are you?" I'm certified chainsaw operator. No one ever asks you any more questions because they'll go, "Oh, the chainsaw guys, they're over there." Now, I've never touched a chainsaw when I've deployed, but I am a certified chainsaw operator. I do have the ticket because these guys are really cool and they're really cool to hang out with. And they have a Facebook page and it's a private group and there's over 2,000 Team Rubicon chainsaw operators. And when you deploy with the team, you want to hang out with really cool people. And chainsaw operators are really cool. So again, there's other things you can do that'll get you on the team. I'm going to talk about a few of my deployments. I'm going to talk about Ebola. I'm going to talk about anthrax. I'm going to talk about biological weapons. Let's start with Ebola. Ebola in West Africa, 2014. I did three deployments. Each deployment was 3 weeks. And there are a number of reasons why I came back in December 2014 and did not do a fourth deployment. And that was because of the pressure that was put on my family. My kids were kicked out of school because dad had been on CNN and the school saw that dad had just come back from West Africa helping Ebola patients. It was a big toll on my family. Ebola 2014, we had over 28,000 cases that we know of. We had over 11,000 deaths that we knew of. 28,000 cases, 11,000 deaths. But in the years since then, it's now believed that up to 70% of all the Ebola cases in Nigeria, Sierra Leone, Liberia, Guinea were missed. So that takes that number in 2014 to over 94,000 cases. And I want to emphasize here of how to be deployment ready when the operate safely when systems, trust, and infrastructure completely fail. My job was to set up Ebola hospitals and work in Ebola hospitals um, in Nigeria, Liberia. One deployment to Nigeria for 3 weeks and two deployments to Liberia. At the same time, around about August 2014, I was on CNN with Wolf Blitzer, and he went, "Well, we can't get ready here in the US because we're waiting for the new CDC Ebola guidelines." And I said, "No, that's absolutely wrong. CDC and my other colleagues that I work with, we've been deploying for Ebola for years, and we know what to do. We know how to protect ourselves. We know how to work in the buddy system. We know how to manage the waste management. We know how to clean up the copious amounts of diarrhea that come out of a Ebola patient." But back in the US, nothing was happening until we got those very first cases, Eric Thomas Duncan in Texas, and we had other cases such as Richard Sacra, Nancy Wright-Bowl, Kent Brantley, and a few other cases that could, and everything changed. But the big discussion as we were seeing this outbreak spread to what, 4 countries in West Africa was the US wasn't ready because we were waiting for the federal government through the CDC to publish the guidelines. And that's not true. We were ready and we were trained. The very first deployment, this is the Ebola response team that I took to Nigeria. In the middle there, the man with the striped shirt is Dr. Parker. He was the Minister of Health for the state of Rivers State in Nigeria. He made the invitation through the embassy to the State Department. I was told to pull a team together. Debbie's in the red shirt, Holly's in the blue shirt. Behind me is Tim. The gentleman behind Tim is Tom. And Tom I'd known for years, and Tom had just been diagnosed with pancreatic cancer. And he called me and said, "Hey, Gav, I hear you're taking a team to Nigeria. Can I come?" And I said, "Well, Tom, let's talk about your diagnosis. Let's talk about whether you." He said, "No, I'm okay. I can do this." I said, "Tom, if anything goes bad, I'm going to be able to help you." And our plan at that stage, our plan B for evacuation in Nigeria was we thought we were going to go to Germany. Then the Germans said, no, they don't want us. So then the US embassy said, "You're going to go to South Africa. If anything goes wrong, we'll get you on a plane, send you to South Africa, and then we'll get all coordinated and work out." And so I said, "Tom, this is the deal. You've been diagnosed with pancreatic cancer." He said, "Hey, I need to do one last big thing." And I took Tom, and it worked out. He passed in 2015 after about 9, 10 months with pancreatic cancer. This team was phenomenal. And in this photo, you'll see there's the military. The gentleman in the hat is the governor of the state. The man in the light uniform, light colored clothing, is the equivalent of our CIA. Are the business people, the people that you talk to, and have, as we try to teach you all this at Penn State, in reality, you will be teaching with a group like this and having to give them answers, operational answers of what to do. This is the team that Tim and I trained in the hospital for the nurse. These are the nurses on how to don and doff the personal protective equipment, how to clean up that copious amounts of diarrhea, how to look after Ebola patients, how to manage the waste management system, how to include, we've got, fluids, water, food, and as much supportive care as we could for Ebola patients. This is the team that Tim and I trained. How they were selected, we never knew. But they were the team. And no one could ever tell us why this team was picked. It was a Wednesday when we got our first Ebola patient. This was the Ebola ambulance. And the patient came in Wednesday afternoon in the back of that vehicle after having copious amounts of diarrhea, really sick, had completely redecorated the whole back of that vehicle. We got the patient, we put them on the gurney, we put them into the hospital, we got them back in. I went through the checklist. Dr. Park and the Minister of Health was back out there, and I went through the checklist and went, "Who's cleaning the ambulance?" And he went, "Why do you ask that, Gavin?" I went, "It's not on the checklist." "Ah, you're right." Okay, Tim and I had to clean the ambulance. So more importantly, we said, no, this will be a train the trainer, learn the learn, get on the PPE, get back there, and we're going to show you how to clean all this diarrhea, swab it, test it, make sure that we've got it safe for the next patient. And we actually did in time, in real time training on how to clean the ambulance. The next day was a Thursday. We got our second patient. We didn't tell the Nigerians this, but they had used Velcro right around the top of that roof of that ambulance, and they'd put plastic there and it created like a swimming pool. So when you put the patient in, the diarrhea was there. They just took all the Velcro off, pulled out the piece of plastic, and went, "Oh, we're just going to hose down the piece of plastic." I went, "Damn, who told you that?" And so don't underestimate in a really challenging situation local decisions, ingenuity. It was just brilliant. And that's how we set up the Ebola hospital. But we got attacked. And we got attacked on our very first night, the Wednesday night. About 1,500 people came to the hospital and attacked the hospital. I've never been so scared in my life. And I hadn't trained for this, but as they were yelling and screaming that we were going to die, I had to make a decision. And I said to the whole team, put your personal protective equipment on. The safest place to hide is with the Ebola patient. So 5 of us all went into the room with the Ebola patient. This was the local hospital. They didn't damage anything. They didn't break anything. They spray painted a lot. And it was our fault. And it was our fault because we didn't engage the local community. We're all so busy in such a hurry to build an Ebola hospital to train nurses that we hadn't engaged the community. And I went on the news. This is the 7:30 report, the big news item here in Nigeria. And this lady here gave me the hardest time of my life of why we were attacked and we didn't engage the community. What was the solution? We took 2 elders from the community. We put them on the hospital executive board. They all wanted $1 million, which they weren't going to get. There were some German lawyers that said, "Oh, you give them $1 million and we'll go away." No, we took 2 of the elders from the community, made them part of the decision-making process, made them part of everything we did operationally, financially, and they would now had permanent positions on the hospital executive board. And we got our second, third patients, and we never got attacked again. But I wanted to emphasize that that was a really challenging interview for me to do because we had made such a mistake. We had to admit we made a mistake. Let's go to anthrax. Anthrax in Afghanistan. So I did 3 tours to Afghanistan, working for the World Health Organization on their EWRS, or their early warning alert and response systems. And a lot of what we had was incomplete data, unreliable data that we had to make decisions on. And I really want to highlight in this example situational awareness and decision making with imperfect information. And at the time that this happened, this was a paper that came out of West Point, and there was a lot of stuff coming out from NATO and the US Department of Defense and West Point and other, really subject matter experts talking about the fact that in November 2008, Al Qaeda biological weapons program, the Malaysian government had released a person who had previously worked with Al Qaeda's anthrax program in Afghanistan. February 2009, a Kuwaiti professor appeared on Al Jazeera television promoting, talking about how wonderful the anthrax attacks were in the United States, and the fact that the Taliban was now having an anthrax biological weapon program. So what happened? Well, we had heard that in a place called Mars Sharif. No, let's go back one. We had heard that there was 12 cases of human cases in Afghanistan, and because of all this chatter and everything going on, everyone thought that this was a biological weapons event. It could have been the Chinese, it could have been the Russians, it could have been the Taliban, but there was 12 people in hospital in Mars Sharif with anthrax. I want to emphasize one thing that you can do as a graduate student, or even someone who's graduated now, is the hostile environment awareness training. You can book it, you can pay for it. And I had done the heat training a number of times. I highly recommend it. It helps you with the skills, the knowledge, the attitudes to improve personal security. It's a really good course, but it was one of the courses, a must-do course if you were going to be deployed to Afghanistan. So we were deployed to Kabul. Other people, subject matter experts from other countries, had already gone to Mars Sharif. We landed in Kabul, went to the embassy. The security officer there said, "Oh, it's bad weather. There's fog. We're going to put you in a helicopter. We're going to fly from Kabul to Mars Sharif. Can't get you there. We need to get you there now. Are you willing to drive?" And Darren and I looked at each other and went, "Drive in Afghanistan? Hell yeah, we'll do that for sure." So we had security, and it's about an 8 hour drive, and we drove from Kabul up towards Mars Sharif, which is the red dot there. You can see where we are in relation to Afghanistan, Iran, Pakistan, Turkmenistan, Tajikistan. What I hadn't realized on the drive up was the Soviet-Afghan war that had gone from 1979 to 1989, that 10-year war. As the Soviets went up, if we just go back, that same road, this is Highway 76, as they'd gone up this highway, they'd left all their tanks on the side of the road. So they're wanting to get us to Mars Sharif. Daryl and I wanting to take photos, as many photos as we could of these tanks, because this is like, whoa, check this out. So we drove up this road, and that's what we saw. And I'd never seen anything like. As we came into Mars Sharif, we saw a photo similar to this. Dead animals. Hundreds of dead animals in the field. We arrived into Mars Sharif. 12 people were in hospital with anthrax. A few had died. We had people from France, Germany, UK. We were the Americans arriving, and everyone's going, "Oh, it's Al Qaeda, it's biological weapons from China, it's the Russians." And Daryl and I sat there and just listened. And then we said, just drove up the road. You guys all flew in. As we drove up the road, we saw all these dead animals in the field. And they went, "What dead animals?" There was this lack of situational awareness. And we said, "Well, has anyone spoken to the patients?" "No." "Has anyone spoken to the patients' families?" "No." This is an act of biological terrorism. We haven't spoken to the patients or the patients' families. Well, maybe we should. And we started to question, going, "We saw a whole bunch of dead animals in the field out there." And they went, "Yes, those animals, we cut meat off those animals." And they told us, like in 5 minutes, what they'd been doing. So we went back out. We had to get it cleared. There were some minefields there and some mines, and we got cleared, and we had there, and we had a field test to test for anthrax in the field, and every animal had anthrax. And so within our 8 hour drive, probably a few hours of being in Mars Sharif, the world is thinking there's a biological weapons event. We've gone, no, it's just really desperate, hungry people wanting, in a food security problem, wanting some food, and they took samples from dead animals, and that's where the anthrax came from. So situational awareness is so, so important. The other thing that I learned, though, is that I wear personal protective equipment a lot, and we had found that the people who had gone to Mars Sharif could put it on, but they hadn't trained as much as we did. So when we were putting on our PPE to go back out to the field where the dead animals were, it was just a mess. Things looking wrong, you all have to look the same. So I wanted to emphasize here that we don't just train before the event, during the event, we train all the time. And once we get to this level where you can put the personal protective equipment on, you then turn the lights out and you practice in the dark. And so, so important to do that. Let's go to Iraq. So I
Actually,
had,
Gavin, can I interrupt really quickly?
yes,
Can
Jen.
we go back to your Ebola? Because we got a question. When you were talking about the hospital and the elders, how did you know who to pick to include on the team? Were the two elders of any specific title in the community?
Right. Yeah. So part of our community engagement that we were guilty for not doing, Jen, was to let the community select. Give them some power. Give them some decision making. Make them feel part of the team. You've got a whole bunch of politicians. You've got us. We were being, at this stage, because we'd messed up, we were being called colonials. And I'd never been called a colonial in my life. And it was a hostile environment. So the idea was we got a group together and we said, here's what we're going to do. We're going to allow two from the community to come and have meetings with us. You just tell us who you want. And we walked out of the room. And they called us back and said, these two people. And we went, okay, you're on the team. Let's go. So again, the community self-selected. Good question. Let's go to Iraq, and we're going there for biological weapons and talking about how public health intersects with national security. Now, I went to Iraq twice looking for biological weapons, and I don't know whether I'm very good at what I do or not very good at what I'm doing. I never found any biological weapons in Iraq. They weren't there. Um, Understanding the absence of evidence versus the evidence of absence, understanding that how to take environmental samples under high political pressure, and then understanding the difference between intelligence, evidence, and scientific proof. And it's really important that we were being told by certain people in the government and the military here in the US, you must find them, and we couldn't find them. And so it's really important to establish scientific integrity under extreme pressure. So in this photo here, you've got Stephen Morse, professor from University of Columbia, Dave Franz. I'd known Dave for years. When he was in charge at Fort Detrick during the anthrax attacks of 2001. But Dave and I had worked together well when I was at NATO headquarters. Craig Vanderwagen from Homeland Security, you might recognize in this photo, and myself in Baghdad. And on the right-hand side is, again, we're in an armored vehicle traveling around, always with bulletproof vests on. Again, you train for this. But what's important is that we had gone to Iraq the first time, found nothing. We went there the second time, and we had really under a lot of pressure and no trust, had to start building up communities of trust with the scientific community in Iraq. And this was at the same time we were talking about the power of global networks for science and public health across various sectors. It was about the same time, 2003, the National Research Council, the National Academies had come out with the concept of dual use research, where we can do more good than harm or more harm than good, education awareness, and how we could look at the same technologies can be used legitimately for human betterment as well as misused for bioterrorism. We had also talked about from this biotechnology research document of dual use, the 7 deadly sins, or it was correctly called the experiments of concern, how to weaponize a biological agent. But then there was an eighth. And that eighth was where we had for years talked about responsible life sciences research, and now we're talking about dual use research of concern based on the equipment. So we had our first trip, we didn't find anything. Our second trip, we said, right, now we have to build a community of practice. We have to get people together. We had no trust. There was no trust in Iraq whatsoever at this stage. So what did we do? We held a conference, May 7th to 9th, 2013. We held what's called the Iraq Biotechnology Conference, which was funded by the US Department of State, Department of Defense through the Defense Threat Reduction Agency, or DETRA. And here are all the people that attended, Iraqis as well as Americans, at that Iraqi Biotechnology Conference. We finished the conference and said, what else can we do? How do we build on this community? We used Facebook, and we created the Iraqi Society for Biotechnology, which is in the left, up the top there, over 3,700 followers. It still exists today, and it helped us create engagement, constant contact, answer questions, and create that community of practice, and eventually develop the trust that didn't exist. I'm going to switch gears and talk about communication. And this is something that I think that we really need to teach at Penn State is, as I tell my students, as you go through your master's program, you are the next leaders. You're the next leaders of public health, the next leaders of bioterrorism, the next leaders of disaster medicine, emergency management. And you're going to be on TV. You're going to be interviewed by journalists. You're going to be asked to be make statements and talk about operational plans, even times when you're not even prepared. So it's really important that you know what you say, how to say it, and how that what you say can actually save and save lives. And you'll be speaking to communities, leaders, the media simultaneously all at once. So one of the things that I do a lot is I train journalists. And here, this is in Washington, D.C., and we go outside, we don't sit in the room. I'm training a group of journalists from the ABC, CNN, um, and other news agencies. I think Reuters was here as well, on how to put on and take off the personal protective equipment, and then how to work, how to actually keep themselves safe. Um, I told them about the buddy system. This is Catherine Diss, and I just heard from Catherine the other day. She was in Ukraine. She's just crossed over the Ukraine border into Russia. She is a journalist with the Australian ABC. And Catherine and I have traveled the world on infectious disease outbreaks and other emergencies. And Catherine, I know, knows how to put on and take off the personal protective equipment and to do it properly and correctly and safely. But she also knows the importance of the buddy system, working with your buddy, help your buddy. And so, again, hope Kat's all right, but I know she's just crossed the border and she's in Russia as we speak right now. I'm going to go back to this problem we had back in 2014, where a lot of hospitals, and we won't have that today because the systems have changed, but the problem we had then was focusing on one pathogen, Ebola. The threat of it coming from West Africa was real, and it did. We had up to about 9 cases here in the US, and the fact that a lot of the hospitals and the health departments, both at the federal, state, local level, were waiting for these CDC Ebola guidelines. If you do you know how many versions of these guidelines came out? 17. And I used to have all 17 piled up on my desk because it was all every time they made an update, they'd print another version. But also sometimes things happen that you have to be a subject matter expert and understand that the doctor was tested and tested negative, but still died of Ebola. And posthumously was tested again and found to have Ebola. It happens. We don't work in a perfect system. Lab results aren't always 100%. How you took the sample, the chain of custody, how you shipped the sample, all can change the laboratory result. But also the challenge we have, and if we don't engage more with journalists, and I've been working with journalists now for over 25 years, is the language they use, especially for infectious disease outbreaks, is fear. Zika virus creates fear. And that should not be what we're telling the people, the community, the public. It should not be what we're telling the professionals. We can do this. We can handle this. But it's always this. I get on every news channel I've ever been on for any disease outbreak, infectious disease outbreak, and it's always how scared everyone should be. And then sometimes we have to venture into areas where we run out of equipment. We don't have enough of the three S's, staff, space, and stuff. And we don't have enough stuff. They start bringing in other machines that we've never seen before and converting them into ventilators. And then we're asked to make comments about, well, the FPA or the federal government, so the FDA, the federal government said this is okay. What do you think? And we're all looking and going, how do we turn it on? How do we clean it? How does this work? Does it work like the machine that we know is made under a quality assurance, quality control program? And this is me in my backyard again, talking about professionals, what we wear. We don't wear masks with vents or valves. We know what we have to do to protect ourselves from high consequence pathogens. And again, it was we're trying to, the federal government's just said, don't do this. Well, I was trying to say, well, the professionals already know this. And the challenge was when you had a shortage of something, people went and grabbed things that weren't right, they weren't correct. One of the things that I wanted to also emphasize during COVID, and something that we do not teach, is how to react to the media when politicians make false claims, and how to be apolitical, how to be neutral, how to say that here's the science, here's the evidence, this is what you can and can't do. And here was something on CNN where we were talking about that President Trump had claimed that they were looking into internal disinfectants. And another thing I wanted to emphasize that we don't teach enough is that when someone gets sick in your house, it doesn't mean that everyone gets sick. And if someone gets sick, you should be able to know how to look after a sick person, how to isolate them in a room, how to clean the bathroom, how to look after someone, how to feed them, how to give them fluids, how to look after, how to clean those utensils so that the rest of the family doesn't get sick. Just because you have a sick person with COVID-19 in your house, don't ever assume that that means everyone else is going to get it. And we don't treat across the whole public community of what we do, we don't teach how to look after sick people in the times of a pandemic. Another area that I want us to focus on is mental resilience. We've all been there. We all have had problems, challenges coming back from a deployment. We rely on those we deployed with. We rely on the community of certified chainsaw operators. Um, and it's really important that we really don't touch on this in graduate school. The psychological stresses during deployments, the burnout, the moral injury, the fatigue, the reintegration after returning home, something that I've really had challenges with when I came back from Bosnia in 1996, or I came back from the tsunami. Oh gosh, after 9 weeks of being deployed to Banda Aceh in 2004, trying to reintegrate back home. Couldn't do it. When I came back from Bosnia, I couldn't leave the house and go into crowds because of the landmines we'd seen over that deployment in 1996. So it's really how do we look after, how do we teach you to look after yourself? And one of the challenges we had during Ebola during 2014 was the number of hospital workers that were infected with Ebola and died. 816 cases across these three countries with 488 deaths. On my second deployment to Liberia, I was going to be in charge of a hospital, which was actually a school converted to a hospital where 26 people, nurses, had already died from Ebola. So I was going in to take over a hospital. 26 nurses had died. What we did, we stopped work. We had 210 patients. I said, no one is going back into that hospital until I'm guaranteed we have the buddy system set up and you can work safely in the personal protective equipment that we have available. So we stopped. People died. It happened. But in a day and a half, we got everyone up to the standard where we all go back in a 24-hour, 7-day-a-week shift basis to safely look after those patients. Yes, we've had some Americans contracted Ebola, and that really changed the funds, the training, and also the work that we were doing. This is in this picture here is Richard Sacra. In the middle is Nancy Wrightbowl, and on the far right-hand side there is Dr. Kent Brantley. But one of the challenges that I've had across my whole career, every disaster, emergency I've been to, I've had to deal with children. I've never been taught how to deal with children. And I don't know whether we actually teach you how to deal with children in times of disasters. And I was at a meeting a few weeks ago at Homeland Security, and someone said, "Oh, we can't look at children as smaller adults." But we still do, because we're not training, we're not teaching how to look after children. Every disaster I've been to, there's been children. And if you look at this photo by Jerome DeLay, I was there the day this photo was taken. What you don't hear is the people behind on the right-hand side, the villagers crying, screaming, yelling at us because this child had Ebola and we're about to put that child in the back of this minivan, taking them to the Ebola hospital because people who were taken to the Ebola hospital got taken there to die. And when we got them to the Ebola hospital, everyone was mixed together, men, women, and children. We didn't have sections for male, female, and kids. They were all together. So we were having men and women and children in the same areas and all treating them the same. And that was wrong. And I still think today it's a huge gap that we need to fill. I want to emphasize that as we walk you through your master's program, as we walk you through public health preparedness, public health is not a desk job. Hands-on learning is so critical and important as well as experiences. Because if I go back to Ebola and I look at mission critical functions for communities, it's this list here. Everything on this page here, which we considered as mission critical functions when we were dealing with communities that either had Ebola patients or communities that are at risk from Ebola. And that's a large list. And when you're an incident commander or when you're in a position of decision making, this is the list you have to make sure it doesn't fail. I also want to emphasize that's what's come out of my deployments is the need and the requirement on how to do daily health self-assessments. And this is becoming more and more common in my deployments. A QR code or a way to log in to some website and do your daily health self-assessment to make sure that you're, 7 o'clock in the morning we start work to make sure you're ready to do to meet the requirements, the jobs that were required from you during the day. But also, and I've got one here, Jen, on my wrist right now. This is a road ID. You can see here that we started wearing during Ebola. I did not want to be a Jane or John Doe. And a lot of the hospital workers didn't carry any ID because we're wearing personal protective equipment. So I can wear a road ID like this one here with all my information. I can clean it with soap and water. I can disinfect it with disinfectant. I can put it back on and put it underneath my personal protective equipment. So I'm never a Jane or John Doe. And so every deployment now, here's the one I've got now, a road ID, and everyone who deploys with me has a road ID. Again, it says here, there's a way you can log into a website with a serial and a PIN number. It's even advanced. I've got a little QR code on the back of this one now where you can just scan my QR code, and again, that will immediately identify who I am. So just to sum up, to finish, deployments is hard. And I want to emphasize, and this sign really resonates with all the work that I've done over the years. Go easy on yourself. You're doing great. This is just really hard. And it really is. And our job, Jen, myself, and the other professors, is to teach you some knowledge, some skills and abilities. And we're going to do better. We're going to work on this. And I think we've done a really good job as we celebrate 20 years, but making sure we can get you deployment ready. Thanks, everyone.
All right, thank you so much, Gavin. We have one question in the chat. You did talk a little bit about what you learned from COVID, but question is, what did you learn from the COVID pandemic?
Yeah, what I learned from the COVID pandemic, just-in-time training is still real. We assumed that everyone could put on a pair of gloves and take the pair of gloves off safely. We assumed that, Jen, when I'm working in a hospital, I could go through 30, 40 N95s a day. I could, in reality. When people started telling me, "Oh, that N95 you wore today," and I was in Boston, at the hospitals in Boston when this happened. They went, "We're going to hang it up under this UV light, and you're going to wear it again tomorrow." And I went, "No, I'm not." Oh, we don't have a new one, and that's where I went to you saw those helmets that Catherine Diss and I went. I wear a powered air purifying respirator. It cost me about $700. I think they're about $1,200 now. But I've got three of them. I use them and I wear them over again. So what COVID taught me was we had thought we were ready. We had the confidence was good because we'd been through other disasters, but when reality came on how to deal with COVID in a pediatric ward, how to deal with COVID in uh, you labor and delivery ward, the fact that all the COVID patients went to the emergency department, no, 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 no. Weren't we going to triage them out in the car park in a nice white tent? I thought that was the plan, and it didn't. It failed. And suddenly the ED is full of Friday night in the ED is busy enough, and Friday night is now with everything that happens as well as COVID patients. Now, as you and I sit here today in 2026, is that still the situation? I'm not sure. I don't know.
Okay, so the answer, somebody, Michelle had answered what she learned. I'm just going to read these so that way they're captured. To be flexible, to know your own boundaries, to be ready, whatever way that means to you, know what your mechanisms are to maintain a clear mind, dancing, exercising, needlework, and reading. And then Michelle also was talking about when you're dealing with kids, playing tends to be helpful. And for youth, it's answering them honestly.
So
And
just
then, oh,
Yep.
go ahead.
Just, so that for that COVID, I spent 8 months away from my family. So the days in just down the road here was we all stayed if we were working in hospital. So I didn't live here in the house. I kept my family safe. And then one big lesson, Jen, when I moved back home, had my work clothes on. I would go to the garage and take them off. I would run naked across the backyard in through the basement door to hop in the shower. And my daughter said, Dad, why do you do that? Because everyone sees you run naked across the backyard. I went, Sweetie, that's because I love you. I want to keep COVID out of the house. And she said, well, why don't you just get changed at the back door? And I went, oh, that'd be a better idea. So I did that. So, but it was that, always that constant. How do I protect my family?
Okay, so next question is frequency of disease outbreaks can drive how often you deploy. But other than that, how do you decide how often to take some of these international trips or deploy? Thinking about sustainability of a lifelong career.
Yeah, that's a really good question. Deployments take it out of you. It's real. I came back from Bosnia, and they gave us 3 months off work. We were so exhausted. I came back, no, gosh, 9 weeks after going to Banda Aceh in 2004, and I think I had about 6 weeks off. No, I got bored. I wanted to go back to work. I wasn't sure what to do with myself in that 6 weeks. The reason I had 3 tours to West Africa in 2014, I came back because of the toll on my family in just before Christmas of December 2000. They wanted me to go back in January, and I said no. One, I was physically, mentally exhausted. There was no way in the world, and I knew at the end of that 3 weeks of the third deployment, I was starting to make mistakes, Jen. I knew that I was getting a little bit sloppy. I wasn't being as vigilant. I was trying to work with the team, make sure we didn't touch our face, that sort of stuff. So it's really, yeah, it's what we live for. Yeah, deployments is that's what it's in our blood. It's what we do. But the challenge we have is how to learn how to look after yourself and look after your team. And more importantly, when you come back, it's so important that the team, as you reintegrate back into family life, um, the team stays together. And having all the different means we have now through social media, I've done that a lot. The team comes back and we just do daily check-ins. It's like a buddy system.
Where can I find opportunities to volunteer to do the work you've done?
Yeah, so locally, the CERTs, the community emergency response teams that we have locally, I think Jen and I have said this for years in our courses. We encourage all of our students to sign up there. There are other organizations. I gave an example like Team Rubicon. Remember, do the FEMA courses, get certified chainsaw license. You got to get that done. You'll never touch a chainsaw, but just have the piece of paper. It's really important. Um, and then international deployments, as I showed at the beginning, the UN system, you have to understand that the sphere standards we've just covered in the course, and those opportunities are there. They're still there today. There's a lot of them. And I would say, with a master's degree like you get from Penn State, that's really powerful. A few other courses again that are free. Most of them are free. I think the hostile evasion course, the heat course. I think it's only like $65 or $100. It's not very much. It's a 3-day course, and I think you do that for 3 days. I think the course is then valid for about 3 years. But when I was going overseas, I was doing that heat course every year, and it's not a lot of money. Getting that as a package deal, that is going to make you deployable.
Okay, I know it's 9 o'clock, but are there any other questions that anyone has for Gavin before we leave? You also don't have to put it in the chat. Feel free to unmute and, I just know not everyone's in a position where they can, so that's why I offered to read them, but you are more than welcome to actually chat if you would like.
I
In this,
actually, oh,
yep,
sorry. I
yep.
have a question real quick. Um, we kind of talked about this in class, with you going back to having to reuse your N95 and me having to reuse it during the hospital. Um, what do you think after going through this pre-COVID, during COVID, post-COVID, to get people to understand, especially in these healthcare settings, that reusing something like that is not adequate, it's not safe, it's not recommended, and to get away from the, well, we can just re-sterilize it or put it under a UV light and it's good to go. That was probably one of the most frustrating things for me was having to no access to things like this, but then materials are being sent uh, other places where people are, able to get them constantly, but then we're here in the OR doing things and we don't even have access to clean, sterile supplies.
Yeah, yeah, really great point, great question there, Patrick. I would emphasize that what we did during a COVID, the same as what we did in Ebola, when 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 the emergencies ended, you go back, if you do your after action review or even afterwards, redo exactly what you did during the COVID pandemic. And during the COVID pandemic, we were telling people to wear that N95 multiple times. It got wet through perspiration. It lost its integrity. And then we were being telling them that after it lost its integrity, its shape, it deformed, wear it the next day. Do that next week. Do that next week in the hospital and see what happens. And everyone goes, I'm not doing that. Then why would you do it during the pandemic? And it's still part of this discussion. And I had a discussion, gosh, only a few weeks ago, and with a bunch of hospital staff, and they said, "Oh gosh, I hope we don't ever go back to the COVID-19 PPE requirements." I went, "Yeah, you will. It's not a maybe; it will happen." And as you saw in those photos, Patrick, I wear a powered air purifying respirator. And goes, "Oh," everyone goes, "Oh, that's $1,200. That's too much." I've got three of them. The one I'm wearing right now, I've had since 2014. It's 12 years old. It works. The battery works. I changed the HEPA filters. It works. And so it's something I've had for 12 years at what, just over $1,000 investment. I value my health. I value the health and safety of my family. The fact that, and this is what we saw, that I saw, Patrick, during the COVID-19 pandemic, going to hospitals and the nurses pulling me aside going, I bought this on Amazon. Can I wear it? Will this work? And I went, I've never heard of that brand. I don't even know what that is. And they'd spent their own money on face masks and personal protective equipment buying from Amazon because they got it shipped overnight. I hope that we don't do that.
Right. Well, and during our run, a hospital I worked at, the OR had allocated one PAPR for a 17-room OR. We did cardiac, we were trauma, we got a lot of patients. So trying to facilitate who gets to use one PAPR, and there were only five in the entire hospital. I got written up, I think it was like 6 times because I refused to reuse an N95. I wasn't going to put in a paper sack and send it to sterile processing. And then they wanted us to start stapling, the straps to it because the straps kept breaking and all these things. So it's just, it's a really hard thing, I think, when we're trying to recruit people, but then, we don't provide what's needed for them to actually safely provide assistance and care. And then when something else comes forward, I know so many people now that have left healthcare because they're not going to jeopardize their health caring for somebody else when they aren't being provided basic PPE that a facility should provide. I mean, even in a private practice clinic, I get all the PPE I could ever dream of and then some. Whereas in the hospital, people are paying out the wazoo for a hospital stay. Um, and yet staff isn't even provided with basic PPE necessities to handle C. diff, let alone some other crisis like, God forbid, COVID or something worse.
Yeah, I agree with you, Patrick. The powered air purifier or PAPA respirator is really good because I work with elderly and they can see my face, and I work with children and the children can see my face. One thing that really freaked me out in Ebola, and I hadn't realized this, when you put children in Ebola hospital and you're wearing the white suits and everything, the kids want to grab onto you and hold onto you, and that really freaked me the first time it happened. Oh my God, child with Ebola has grabbed my arm and won't let go. But it was their way of saying, I need comfort. And so again, N95, everything else covers up all your mouth, your facial expressions, the nice big open faceplate of a Papa, I think helps the work we do.
So I have to say, only in a situation like this would we get a comment like, "I love air purifiers and HEPA filters." So Kirsten, that is great. I love that. Um, so we got a question from Kevin. What do you think is the next infectious disease of concern?
Well, that's a great question, Kevin. And so when I worked for State Department and we was trying to predict, and this is how I met Mike Osterholm, we got it wrong every time. And so we were preparing for the next bird flu pandemic or the next influenza pandemic, and no one had Mexico on their list back in 2009. And then the swine flu pandemic came from Mexico. I went, what? I went through the top 10 list of countries. Mexico wasn't on that list. So it was like, give up. Just cover everything. Do your risk assessments, get good surveillance systems in place, get good community engagement, talk to people, and when you hear of clusters or unusual events, make sure there is a means to report that unusual event so that we can then do a risk assessment and work out how to act on it. So trying to guess what's next. Bats carry a lot of things. There's still a lot of coronaviruses out there that we are looking at. Bird flu, H5N1, and all the other different combinations of the H's still worry me a lot, especially when we had a case recently in Seattle of an avian influenza that we really haven't seen cross the barrier from animals to human, that spillover. That worries me. And again, the population of the world's getting bigger, which means we're encroaching more on the environment where there are animals, and we're going to have the threat of zoonotic diseases. Zika, did we predict Zika? No. No one thought anything about Aedes aegypti bringing in the Zika virus, which came from Brazil and then spread around the world. Missed that one as well.
So we have a comment. I'm an RN and PPE allocation during the pandemic was depressing. I was given one N95 to use for an indefinite amount of time. Um, and then Gretchen, at least in the US, the wastewater surveillance has been invaluable. I hope that continues.
That, Gretchen, has been phenomenal. Remember the cluster of polio patients they found in New York City? And through the wastewater, they were able to trace it back to the zip code, then the street, then the building, and then bang, they found the population who flushed the toilet with polio. That's amazing. The weakness in the system right now is it's not in every zip code, every jurisdiction, every state, and it's more of a voluntary system. And when you actually look at that wastewater system and how amazing it is, using real-time PCR to pick up pieces of DNA, that's incredible. And if we could do that everywhere, it would be much safer. I'm very grateful for the jurisdictions and the governments and that have voluntarily do that on a regular basis. But as we see resources and funding get cut, these critical surveillance programs, we're not sure of the future. I know Jen and I have talked about this a lot, and these are systems that work well, but again, have to go to scale.
Hey, Gretchen, isn't that how the field of epidemiology began in England?
And of course, she's referring to Jon Snow and the cholera outbreak and the fact that he took the handles off the water pumps.
Huge investment in biosurveillance happening currently in DOW across multiple AORs. Yes.
Oh, really? That's from Dave.
Yeah, hey Gavin, long time.
It has been.
Yeah, glad I got to call in tonight. Yeah, so that's been a big strategic push, especially in the Indo-PACOM AOR. But we are heavily leaning into biosurveillance, wastewater surveillance, setting up sites all over the Pacific Rim, and then looking at the additional AORs, UCOM, CENTCOM. Started up probably tail into COVID and really is taking hold right now. Big investments this year are happening.
Well, thanks, Dave. I wasn't aware of that. And it's interesting, my first deployment to Afghanistan, I had a big black box, which was a secret. It was called a Rapid. And it was a rapid real-time PCR machine. And they always said when I went to sign it out and travel to Afghanistan, if I lose it, I'm going to go to jail. It was that important. But again, that big black box is now the size of a cell phone, is now commercially available. In what's that, 15, 16 years? And so grateful if there's more if Dave has just outlined there's more investment in biosurveillance through Department of War, that's going to help the greater good and everything else, because so much of that technology we had in the 2000s that we used for biological weapons and other high consequence disease is now commercially available to anyone.
I see a couple people unmuted. Are you unmuted to ask a question?
Oh, just not paying attention.
Oh, no worries, no worries. Just wanted to make sure I didn't miss anybody.
How are you, Michelle?
I'm good. Feels good to be back in PHP world.
Well, we're glad to have you back.
And
And
go,
oh,
Jen.
go ahead, Gavin.
And I think one thing I remember you and Chulapol shared with me some of the studies that our students have done. I think it's really important that some of those capstones, some of those projects have just been so remarkable. The one that we worked with Joan when she looked at vaccination rates in Nigeria between Boko Haram and a terrorist held area versus areas where the terrorist group Boko Haram was not, and looking at vaccination rates and how amazing that's. So, and then she went to the World Disaster Emergency Medicine Conference and she won the
Hmm.
first prize in the poster. But things like that. I'm so glad you've done this, Jen, in a way to celebrate all the things that we've done over the 20 years. It's wonderful.
So what Gavin is referring to is so as you all know, everybody in the master's program has to do a capstone. And previously what we would do is we would keep a running list of the student and their capstone topic. But with Chulapol's amazing IT expertise, he is my go-to guy for everything, and he always answers my emails, which I probably would have stopped answering them forever ago. But we have created an actual library of those capstone projects. So now we will have a running library where you can actually click on them and pull up the project. So all that amazing work that students have done is available, and we can use them as references. But also, when we have students coming up through the program, they can get an idea of like the type of capstones that they can do. They can get inspiration. If a student has done something amazing that a current student is interested in, they can kind of pick up where that first student left off and take it to that next step. So really excited about that. And what we do now is we had sent an email out to as many alumni as we could, asking if they would be okay if we put their capstone in that library. And then now, as part of the capstone class, that's a question that we ask before the final week. And if, will you allow us to put it in there? And then if students do, then we put it right in there at the end of the semester. So we can keep adding to that database. And I know I keep saying this, and I'm sure people think I'm either lying or crazy, but we have such amazing students with such amazing work, and they're picking great topics that are really making a difference. And I just wanted to see a place where we could all have that information and not have, people graduate and be lost, which actually segues into the point that I was going to make. As I was watching people log in tonight, um, I love the fact that these webinars and our book club and our IEM program have such a diverse group of students and graduates and faculty who come. And I keep telling people, like, we love it when you graduate because we love cheering you on as you walk across the stage. But the fact that we've got all of these avenues where we can still work with you and have these discussions and get to spend time with you is great, because when you graduate, we're so glad that so many students still come, or so many graduates still come back and want to do these things with us, because we love having you. And these are yes, the library is up and running. There aren't many things in it yet, but we can definitely share the link. But yes, so thank you for making that effort after you graduate to still come back, because we love that, and it really goes to reinforce how special this program is. Chulapol, do you have the link easily accessible? Because I do not know.
Give me a minute.
Sure.
Do we know
Did and
who's
oh,
sending out emails to alumni and where they're going?
so that's an interesting question. We have tried to build an alumni database with email addresses just for our program, and it's been difficult. So we tried it for a while. We were doing a newsletter, and we really didn't have that many alumni email addresses that weren't Penn State addresses that they lost, or that that got
The
turned off.
psu.edu.
Yeah. So
Mhm.
if that's something that I would love to be able to do, and Chulapol put the capstone library in the chat. But yeah, that's something that I would love to do. And I probably shouldn't say this in front of you, Michelle, but I always tell people when we're asking for this information, like, we're not an alumni association. We're not going to ask you for money. We just want to stay in touch for things like this. Trust
No, but
me.
I mean, like, but I'm not getting those emails, so
Yeah,
that's why I asked. Yes, I have an ear to the Alumni Association, to World Campus. Yes, Read Across America just happened. That came out of my head. So, Homeland Security is well into that space.
yeah.
So no, I'm not asking because of that. I'm asking
No, I know
because,
you're not.
yeah,
Yeah, so I wasn't getting those emails either on the alumni side. So I was trying to parse out what exactly we had and what we didn't, and it's a work in progress. But if we do send emails out, that's also why I like to use LinkedIn, because even if people don't give us their email address, but they've connected
yeah,
with us in our group there, then they can still see the announcements for things like this. Um, so we're trying.
yes. No, all good things, all good things.
I wish we had a better distro, because I would love to share these things. Even when we do like the clothing sales and things like that, I wish that there was a good, easy way to get the information out to people who have graduated but are still interested in stuff like this.
We could be creative.
I was gonna say, if you have ideas, let me know. I would love to hear them.
Good news. Creativity is one of my unmatchable uh, skills.
That's
I
that's
can't use
always a good one.
chainsaws, but I can teach you things. I can be creative.
Definitely an important skill.
Mhm.
Are there any other Gavin questions or program questions or anything that anybody would like to chat about before we end tonight?
I think one point, Jen, is we're here to help.
Yes, definitely. Always. Oh, JD, are you talking? Because if you are,
Can you hear me now?
yes.
I was just saying thanks a lot. As always, very interesting, Gavin. So it's good to see y'all.
See you, Jody.
You too. All right. Well, if there are no more questions, then again, we've got IAEM next week, fireside chat with Dr. Osterholm on the 16th, and then PHP webinar on April 1st. And again, that's with Dr. Cherry talking about kicking off our program and how it came to be. And if you are a current student, summer class registration is open and available. So hope to see you all soon at one of those events we just talked about. And thank you again, Gavin. We appreciate it.
Thanks, everyone. Thanks, Jen. Pleasure.
Thank you. Have a great night, everyone.